Welcome to the DaVinci Hour, a podcast series that interviews individuals across the field of medicine to help provide an inside look into their experiences and provide insight on how to navigate the journey of becoming a physician. My name is Dr. Maxwell Cooper, and I will be your host. This podcast is brought to you by DaVinci Academy, a medical education company that provides online video courses, outline format books, and clinical case videos for students studying the medical basic sciences. You can check out all that DaVinci Academy has to offer at www.dviacademy.com. All right, everybody, welcome back to another episode of the DaVinci Hour. Really excited about this one. We've got my colleague and my co-resident, in fact, Dr. John Moon, one of the integrated interventional radiology residents here at Emory University in Atlanta, Georgia. And he's a good friend of mine, good collaborator of mine. He's, in addition to being an IR resident, he's a medical innovator. John, we're happy to have you here on the program.
Thanks for having me. Glad to be here.
Awesome. So just a little bit of background on who Dr. Moon is. Like I said, he's a resident physician here in the integrated interventional radiology program at Emory, and we'll get more into that in a little bit here. He did his intern year with me here as well in the transitional year program through Department of Medicine. He got his BA at Vassar College in biological sciences and an MD at Albany Medical College in Albany, New York, before coming down here south. And then he's also the founder and CEO of BioFlow Medical Devices, which is a medical device company developing novel percutaneous catheters. So we'll definitely get into that and get his thoughts on medical innovation as well. So it should be a great episode here for you. So I think, John, we'll start with kind of a key question. We were talking about it before we started recording the episode is, I think, everyone hears about IR and it sounds really cool, but I guess I feel like, and we talk about this all the time, that not a lot of people know. They know maybe bits and pieces of what IR does, but they don't really know fully what it is. So I would say the first question to you is what is interventional radiology? And I guess what type of patients do we see? What type of pathology do we treat and so forth? What type of procedures?
Yeah, no, absolutely. I think that's a very fair question and one that's being addressed more and more in the medical education curriculum. But to try to be as succinct as possible, IR encompasses a lot of different pathology. It touches almost upon every organ system. And if you think of a patient population, IR probably has some sort of role in treating them. And really, the acuity can vary from extremely stable patients to patients who are rapidly decompensating. As an example, we can talk about venous interventions. And from the stable perspective, we might see patients that are coming in pretty routinely for our clinical providers or colleagues on the wards. And we may place difficult central venous catheters for them for the administration of antibiotics, inotropic support, perhaps for patients in the ICU, or for dialysis maintenance for our nephrologists in the treatment of renal disease. And the more intensive cases, we're treating venous thrombotic or thromboembolic diseases by way of thrombectomy. And then we can also talk about peripheral artery disease with stents, arterial venous malformations with embolic. And then we're also routinely involved in acute GI interventions or gastrointestinal interventions. In the stable patient, we may assist the primary team by way of percutaneous enteric tubes or G tubes placed through fluoroscopy and minimally invasive image guidance. And then in some trauma cases, as we might see in the larger trauma centers, we provide our expertise by way of embolizing arteries that we identify that are acutely bleeding, and we stabilize patients that way. And then one of the more commonly taught, I should say, in the medical curriculum is TIPS, or transhepatic intrahepatic portosystemic shunt, which is a procedure we use to stabilize end-stage liver disease patients who are refractory to endoscopic, for example, variceal ligation. So I've listed a few systems just there, but we also perform biliary interventions involving biliary stenting for malignant obstruction, percutaneous cystoscopy for stone removal more recently, and then different therapies that are developed only, they continue to innovate on the latest technologies available, and we really make it our own, procedure or device in treating patients through image guidance. I'd be remiss not to mention IR's role in interventional oncology, otherwise known now as the fourth pillar of oncology. IR is extremely active in providing local regional therapies, be it percutaneous thermal ablation, chemical ablation, or intra-arterial delivery of chemoembolic agents known as TACE, or radioembolic agents known as TAR or TARE. And I could go on, and there's more to be said about IR's role in like GU or pelvic interventions, where there's uterine fibroid embolization to treat pelvic fibroid pain, or prostate artery embolization for the treatment of sequelae of benign prostatic hyperplasia. But really, the overarching theme is that IR, or interventional radiology, is involved in the treatment of disease or different pathology through image-guided, minimally invasive interventions. And I know we were recently talking, and this kind of goes into another field of like pain interventions, where we were talking about your involvement in like recent nerve ablations for the treatment of knee pain. So, I mean, there's just a whole spectrum of pathology that we treat. And this happens both in the inpatient setting and the outpatient setting. And we see our patients in the clinic after these procedures routinely.
No, I think that's excuse me, an excellent answer. I think you gave a good synopsis of how you said how IR is involved in literally head to toe every organ system. The only one you didn't describe was like neurointerventional procedures as well. I mean, thrombectomy used to treat stroke, and coiling aneurysms and things like that, which both interventional radiologists and then obviously our neurosurgery and neurology colleagues do those as well. Some of them, I think really IR touches everything except for coronary stenting. I mean, coronary like angiography is really kind of the main, those are really not outside of that. I think we do pretty much hit every other organ system. And ironically enough, the Palmez stent, as we often talk about, was invented by an interventional radiologist. So the original coronary stent was actually invented by an IR doctor. So I think that's interesting. And then, some IRs still do, it's not as common anymore, but they'll do, endovascular repair of aortic aneurysms, just like vascular surgeons do. So yeah, I think, you gave an excellent point about how it's just it's probably, if not the most evolving field in medicine, which is pretty amazing. So yeah, I think as I've told you, I'll never forget my first day rotating as a resident on it, that we did a kyphoplasty for spinal fractures in one room. Then the next room we put in a quick line. Then the next room we did a nerve ablation. And then the next room we were doing a uterine fibroid embolization. So we were hitting like, the musculoskeletal system, the nervous system, and then the female reproductive system all in one day, which is pretty amazing.
Yeah, I think it's that variety of practice that's really attractive. Really treating all sorts of pathology with the principle of, minimally invasive image-guided procedures. And really, and from my perspective, and we'll get into this later, I think it's really the future of surgery.
Yeah. No, and I think another important thing to point out is how a lot of these procedures are done outpatient, or a lot of them are done under like moderate sedation and without the need of like, endotracheal intubation or anesthesia or anything like that.
Right.
Which is also, I think, further innovating. So we've talked about what IR is. Obviously, we'll get even more into it as we talk here further. But I think, as I mentioned, you're an integrated IR resident. So I guess what does an integrated interventional radiology residency consist of? And I guess going off that, how does it differ from a diagnostic radiology residency? So because I think people may be wondering kind of what the difference is as well.
Yeah. So to break it down by anatomy, I suppose, it consists of 6 years of training. The first year is going to be that internship year. The next 3 following that are going to be your core diagnostic rotations in diagnostic radiology. And then the last 2 years are really dedicated to your IR rotations or IR related rotations. And the idea behind the integrated IR residency is to really provide a direct pathway for medical students who know that they want to do interventional radiology, and to really dedicate them, those 6 years towards honing their craft to that end.
Nice. So I guess like kind of getting into it, what are the different training pathways? Because you hear these terms, integrated IR, ESIR, independent pathway. I guess could you maybe touch a little bit on the differences between those three main pathways to becoming an interventional radiologist?
Yeah, absolutely. So, I mean, there's the integrated residency, as I just mentioned.
Hmm.
So it's a 1+3+2 sort of situation. And then there's the ESIR, or the early specialization in IR pathway, which allows for diagnostic residents, perhaps who were not sure that they wanted to commit to integrated pathway. These diagnostic residents that then decide that maybe after rotating through a variety of rotations that IR is indeed what they want to pursue. They have the option of completing different milestones within IR, and in many cases, I think the SIR states that it's 500 IR related procedures, and then the completion of 12 IR or IR related rotations. And what this allows for them to do during their diagnostic residency is then to, instead of going into a 2-year independent residency, they can then enter the second year of that independent residency, effectively shortening it by a year. And then functionally, it ends up being, from a time perspective, as long as it would be from an integrated residency. And so I touched upon the independent residency, and that's sort of the last pathway, which is you complete a standard 5-year residency with that intern year included, and then you go on to do a 2-year quote unquote fellowship, or what they now refer to as independent residency. And the utility of ESIR is that you'd be able to shorten the time you'd be doing that independent residency.
Nice. No, I think that's a great synopsis. And I think that, there's pros and cons, everyone. I think, like you said, the integrated IR is for the people who, I think, like yourself, were very sure you wanted to do it. And I think, to me, I feel like, tell me if you disagree, I feel like the major advantage of that is you don't have to do a fellowship match or the independent resident match. Like you're staying at Emory for all of your training. You don't have to worry about, doing ERAS and all that stuff again, doing interviews, and you won't have to learn a new system, a new program. I guess I feel like that's maybe the biggest advantage. I don't know. How do you feel about that?
Yeah, I think there's definitely uh, some sense of security, I think, in knowing that I'll be at one institution for all of my training. Um, and I think there could be pros or cons to that, real or theoretical. I think for me, one of the biggest benefits is that I had family in the South. I knew I wanted to be in Atlanta, in Emory, and that would provide close access logistically to support systems. In addition to the type of environment I was looking for, I knew that being at Emory would provide access to certain academic networks, which include the Georgia Tech network, or the different academic systems in the greater Atlanta area. Um, and given my interest in innovation, which we touched upon, it just makes a lot of sense for me to really hone in on the different things I want to accomplish here during this dedicated, integrated 6-year program. And so I think for myself, there were a lot of benefits to that, and I knew I wanted to do this up front, and so it just made sense to apply to an integrated program where all of my interests align. But I think and we people talk about this throughout the process, and even now amongst like the different co-residents, that the ESIR track may also offer sort of an advantage from experiencing different practice types or institutional differences, or really widening your arsenal of skill sets or way of doing things by interacting with different attendings. And contrary to what people might think, IR, or like these different procedures that, or surgical therapies that people perform, there's a lot of operator differences, a lot of variety in the way people accomplish things, and principles that they focus on, or that are highlighted. And I think you can appreciate more perhaps a greater variety if you go somewhere else. But um, all the same, I mean, you could make the argument that you really hone in on the variety of skill sets by staying at one institution all the same and really making them your own. So it really depends on what you're looking for, I think, and one's not necessarily better than the other. It really is just how you fit into that pathway.
Mhm. Yeah, and I think that's, the option to go somewhere else in your last year is, some may think of that as a advantage of the ESIR track. I think the biggest advantage, like you said, is it's for, if you're like myself, I wasn't sure 100% I wanted to commit to an IR program. So, I'm a diagnostic resident technically, but will likely be, applying for the ESIR track at the end of, not this year, but next year, I believe. So, it gave me a chance to do a couple rotations. Ironically, I'm on IR right now. That's why we're recording this so late. And so it's a late day today out there, but yeah, it's given me a chance to really experience it as a resident. It's my, I did a rotation during our intern year, as you did, and then doing it again here as a resident, radiology resident. It's just further confirmed that it's something I'm very passionate about. And I think I have the option, I can stay at Emory, or I can go somewhere else, and what how that goes, we'll see. We'll see where the chips fall in a few years. I don't have any preference one way or the other right now. But I guess it's nice to know I have that option. I don't have maybe the level of security you do, but definitely, I think you make a good point too. Just like how in different surgical practices or surgical programs, for example, in like, general surgery, there's some programs that are, very high volume transplant, like here at Emory, it's a very high volume transplant center. So the general surgery residents here get a lot of exposure to that. But they may not get as much exposure to something else. So and it's the same thing in IR. Like here we do, because of being a transplant center, we do a lot of tips and hepatic work. But you could go somewhere else where certain places do a lot more oncology or more peripheral vascular disease, things like that. So like you said, that's kind of maybe the advantage. I think the 2-year pathway is maybe the one that's like the least desirable, the one where you have to, because it's just 7 years, it's a year longer. I guess it's not the end of the world if you have to do that, but I guess if there's one path out of the way that's the least desirable, I guess maybe that's the least desirable of the 3 pathways.
Yeah, I think it just kind of depends on like when you come to deciding to do IR
Mhm.
and where you are in having prepared for that. And that may just look different depending on, your personal paths of interest, or the residency program that you're part of maybe doesn't offer ESIR.
Mhm.
And so it may be out of necessity, but certainly I think there's an appeal in the former pathways in that it allows for shortening an already long or lengthy career path, which is most of medicine, right?
Yeah, anything you want to do that specializes super long. I guess so. Touching on that, we'll touch on, I think, a lot of medical students. The med student that was on today, we were actually talking about it, was the different intern year options. I think from what I understand, and correct me wrong, really there's 3 main options. Is the preliminary medicine year, where you're basically you function as a full-time internal medicine resident for an entire year, with the understanding that you'll go ahead, because I think people need to understand that in radiology, both integrated IR and diagnostic, you match like a year ahead essentially. It's like dermatology or anesthesia or some of those other specialties, and then you do that intern year before. And then the other options, you could do an integrated, or a preliminary surgery year, where you would function as a general surgery resident for a year, and that's as we'll talk about, becoming a little more popular with some people in IR because of the a lot of the overlap of kind of surgical skills and managing pre and post operative patients. And then the transitional year, like we did, which is typically, as ours was, run through the Department of Medicine. Sometimes I think it's run through like the Department of Family Medicine, which is generally, you still do a lot of internal medicine rotations, but you also have like usually more elective time than like a prelim year in medicine or surgery. And I don't think there's really any other options. Are there other that you can think
No,
of?
not that I can. I mean, I think those are the 3 that I was looking at. If there's
Yeah.
more, it's not to my knowledge. But to I think kind of answer perhaps, or to kind of talk about what your medical student was um, referring to. I mean, there's these three different options. And I would preface all of this by saying that it really depends on what you're hoping to get out of your intern year.
Mhm.
And not everyone is about like maximizing training, efficiency or output or learning. And so sometimes it's a personal decision that factors in like logistics of moving, proximity to family, consideration of significant others, et cetera, et cetera. That said, I completed my transitional here at Emory with you, as you know, which, contrary to the reputation of many transitional programs, was rather quite rigorous. Um, I would say that, like, retrospectively, I think the goal of any internship year for radiology residents, or in general, should be, in addition to IR residents, is to develop a solid clinical foundation. And then if that's accomplished through a medicine preliminary year, a surgery preliminary year, or transitional year, as was in my case or our case, I think the overarching objective is met. Now, you brought up a great point. Like, a lot of program directors or programs are now moving towards a categorical system where they match into both their internship and their advanced program together. And for medical students that don't know, in specialties with advanced programs such as radiology, you apply into these internship programs, and then you also separately apply many times into the radiology program of choice. And some programs have what's called a categorical program, which combines both of those things together. And so you just apply to one program, which encompasses both of those things. So for you and I, we applied to both the transitional, which was the internship portion, and we also applied to the advanced program, which was our radiology portion. And then, like we were saying, a lot of these programs are transitioning to a categorical system where they incorporate a surgical year. And there's certainly a preference, I think, for program directors, given that there is high crossover or overlap between the sorts of things that IRs do as proceduralists or minimally invasive surgeons, or we'll call you, and what the surgical services of a hospital do. I think there's a lot of arguments for and against, probably more for, but I think, and I think, most people will say this, is that it's really program specific. You could go to a large surgical program and perhaps not get the operative experiences you were looking for, or as much of the clinical experiences you thought you would get. Or, you could go to a really fantastic community surgical program and get all of the things that you're hoping for, but perhaps not the major cases that you might see at your advanced program. But at the end of the day, it really depends on the rigor of training that your internship provides, whether that be a medicine prelim, surgery prelim, or TY. And at least personally speaking, I know that we co-managed a lot of these surgical patients at the different hospitals we rotated at during our year. And I can confidently say that I left intern year with a solid clinical foundation, which I believe will serve me very well throughout my radiology years, which include the IR years as well. So I think to make this long answer, I guess a bit shorter, it really depends on what you're looking for. I think you have to identify what's important to you personally, and then what you hope to get out from a training perspective, and to see if that aligns with the internship program that you're looking at. Because they're really, you categorize them into these three things, but really there's different degrees of, work or clinical exposure that you get across the three of them.
Yeah, no, I think that's an excellent synopsis. And, I think what you said, I echo a lot as well. It's really what you kind of want to get out of your intern year. That's kind of what I usually say to med students when they ask me about it. I think no matter what, like kind of what you touched on with all three of them, in my opinion, you're gonna work really hard. Obviously, there's some programs that are harder than others, and then there's some transitional year programs that are quote unquote a little bit more chill than others, like chiller certainly than the one we did. But some people may think, oh, the clinical training maybe wasn't as rigorous. That's up for debate. Whether what the quality was. I can't speak to that. But I think you know either way, you're going to do a lot of like grunt work, for lack of a better way of describing it. You're going to write a lot of notes, whether you do a surgery year, a transitional year, prelim medicine year, things like that. A lot of the like functional things to kind of get patient care done, you're going to do that no matter what. I think the surgery year, maybe the benefit, and you're kind of touching on it, is you're definitely, I don't think you suture much at all as a medicine intern or as a transitional year, unless you do surgical electives during your transitional year. I think the other thing that surgery interns are considerably probably better at managing are like simple things like dressings, stuff like that. I don't think medicine residents, we didn't you don't deal with that as much, like the different dressings, how to dress different wounds and things like that, how to deal with drains, like those types of things. So I think maybe those could be possible advantages to a surgery year. But then you're going to do a lot of things that and that's the other thing, I think, across all three of them, you're going to do a lot of things you're probably never going to do again. And how useful those are is, kind of up for opinion out there. But I think the advantages of the medicine, like doing internal medicine for sure, is, you need to know how to, as an IR, you need to know how to manage blood pressure to a certain extent. If someone's blood pressure is really high during a case, or someone's blood pressure, if the nurse calls you afterwards and the blood pressure is high in the post-operative or in the post-procedural area, things like that. You won't necessarily be running insulin sliding scale, but
Right.
you should at least know, like, how to work up. I think the basic knowledge you want to know is how to work up patients, how to clinically evaluate them and clinically think. And if you get, regardless of which path you take, if you get that, like you said, how you got with our intern year, and I feel the same way. I would echo, our TY year was certainly more challenging than, or more rigorous than some other programs, but I feel very comfortable clinically after that year for sure.
Yeah, yeah, and I think to kind of add, it's hard to have this perspective of what kind of uh, interventional radiologist you're going to be, but I think there certainly is a push from the Society of Interventional Radiology to really highlight the more clinical aspects of interventional radiology, and to really push for a stronger clinical presence, and really taking care of the patient from the moment we get consulted, all the way to following up with them post procedurally and regular follow up visits. And I think we are recognized officially as a primary specialty. And so, how far you want to take your medical management of a patient, whether it be hypertension or diabetes or these other common medicine pathologies, is really a function of how proficient or how comfortable you are in treating those entities. And so I think, it's really, there is that sort of, 2,000-foot view of looking at where you want to be or what kind of IR you want to be down the road. But I would also add that, I felt that having a general year of medicine, and knowing how to do general doctor things would be of greater benefit to myself personally. And I was more intrigued by it. And so I was, these surgical things I will have to learn eventually, but this year of medicine is something I'll never be able to experience again. And so in that respect, I found it highly valuable.
Yeah, no, and I would agree with that. I mean, I would say, I think I speak for both of us. We're both very comfortable. We could, even though it's very early in our, we're not that far removed from our intern year. I think we could, walk into the hospital right now and still feel comfortable, working up heart failure, just bread and butter type medicine things, heart failure, pneumonia, pulmonary embolism, those type of things. And I think, we'll still, feel comfortable with medicine things and like, essentially be able to speak their language. Because one thing you do, I was doing it today, is you're on the phone with, ordering providers all the time, both in diagnostic and interventional radiology. And I think being able to speak the language with both of them is certainly very important. Um, so yeah.
Yeah, it's interesting. We feel comfortable in a lot of these bread and butter pathologies, and I think one of the limitations of our knowledge is, or one of the things that I learned during intern year is like to know what you like, when to talk to someone else, like
Hmm.
know your own threshold for calling someone, like whether it's the cardiology service or the GI service, and knowing to recognize those critical moments in care that you you identify a problem that you can't solve or require the expertise of another consultant and call them.
Hmm.
And I think being on the primary service side of things really gives you a lot of perspective into who your referring providers or what they're thinking about and what they're looking for, and how you can really contribute towards patient care as part of their treatment plan. So I think whatever you choose, just it's more than just like the name of that year, whether it's the medicine or the surgical or the TY year. It's really about what you're doing in the sort of program or um, rotations they have laid out for you.
Hmm. Yeah, and I think last thing I'll point out here is, I see one advantage of doing like a transitional year is you can do surgery. Obviously you'll do a lot of medicine, but you can do surgery electives in a transitional year. Like I did, as you know, I did a month of vascular surgery here at Emory. And so I got to, rotate on the vascular service and see how they do things and scrub in on some endovascular cases, which definitely has, a lot of overlap with interventional radiology, and, kind of see the surgeon's perspective of things a little bit.
Mhm.
Um, and I definitely picked up some valuable skills from that as well. So I think for me, it was good to see like both sides, obviously much more slanted towards medicine. But I think getting, there's also like an advantage to that too. I think if you can go to a program that'll allow you to, do some electives and some other things, for sure.
Yeah, no doubt. Completely agree.
Um, so I think it's funny me asking you this because I'm on IR right now, but I'll ask you since you obviously know as well as I do. So people are probably wondering, like, we've kind of laid it out, the landscape. What does like a typical day on the IR rotation look like for a resident?
Yeah, I think we can tag team this one.
What
But as you work up patients in the morning or the night before. You chart on them in the morning. You see the patients if they're inpatient. You
Mhm.
consent them if they haven't been already. Then you prepare the list. You prepare all your images. You present them to the team. You round with the team, and then things start moving. Yeah, the day begins, and you're scrubbing into procedures. You're logging cases. You're dictating reports. You're following up with family. You're following up with providers, and then you're working up consults throughout the day and just doing a modified version of everything I just said on repeat.
Mhm.
And that's how your day runs. And you run through like 6 or 7 or 8 or 9 or 10 different cases of all sorts of variety, and before you know it, the day's over and you've had a wonderful day of fun.
That's right. Even if you get out at 7:30.
Exactly.
No, I think you pretty much hit it. I think like you said, there's a lot. It's a very which is cool about it. It can be hectic, but is cool is there's a variety of things you're doing. You're seeing patients in the hospital, you're doing outpatient, procedures on patients in the hospital, patients that are coming in from the outpatient as well. You're seeing consults from in the hospital as well, which is you're essentially, I wouldn't say a primary service because you're not like the primary team, but you have your kind of primary scheduled procedures for that day. And then obviously you can have a lot of consults and add-ons and things like that. And I'll add that a consult, is not just looking at the imaging and kind of chart checking. Like you go up to the floor, just like, a surgical, it's functions, I would say very much like a surgical service. Like you said, it's, you go up on the floor and you see the patient yourself and examine them, and whichever and what type of exam you do is kind of relevant to the procedure. If someone calls you for like a biliary drain because they have elevated liver enzymes, you're going to go up and, obviously examine their abdomen, see if they're jaundiced, labs, you'll review their, liver enzymes, their bilirubin, things like that. So it's a lot of clinical evaluation. It's not quite to the extent as a medicine doctor, but because you're kind of more focused on the, problem at hand, or the problem you're being asked about. But
Mm-hmm.
a lot of clinical evaluation for sure.
Yeah, definitely.
Yeah, and I feel like the rest of it kind of runs, like you say, you run through the patients, and then you kind of, usually that's it. I think it depends like what level you're at. Like at our level, we're doing a lot more of the consenting, and the lower junior resident level, consenting patients, seeing consults, coordinating with teams, ordering teams and stuff like that. And then the fellow, I think you're at that stage, you're still doing some of those things, but I feel like at that stage it's more kind of honing your skills, as an operator.
Exactly. Yeah, no, totally.
So I guess we've talked about what the rotation looks like. So I guess people, a lot of med students wonder about the schedule, like what type of hours do we work, especially on IR. I think we should probably address diagnostic too as well, because I think it's important to point out, and you can elaborate on this, is that a lot of our training, we're still trained as diagnostic. Even yourself as an integrated IR resident, you're still trained as a diagnostic radiologist as well. And I guess like what is our call schedule? Because like IR is certainly on call all the time.
Yeah, so I mean, once again, I think it's very program specific. I think the diagnostic years, and it's relative to what you're comparing it to. If you're comparing the diagnostic years to like a general surgery residency, I mean, I think objectively we could probably say that the diagnostic radiology residency requires less hours in the hospital. That said, as we're both going through our first year of radiology residency, we can say that certainly there's more free time than we may have had during our intern year. But I think the expectation is also that we use that time to really study our craft, and to really learn this new language that we have to communicate through our, evaluation of images. And so I think the first year is structured wherever you go for radiology to accommodate that learning curve that's very difficult. And I think the second year, you're picking up more call, and then your third year you're picking up more call, and then come fourth year, or your R4 year, you're doing these mini fellowships, a variety of electives, and really jumping into whatever specialty that you've chosen to pursue, as many now do pursue subspecialty training. That said, I think for the subspecialty of IR that we'll be pursuing, I think it's variable on the institution size and the number of trainees available, and the sort of maybe even the practice model that the trainee is at. And so, I've heard anywhere between the worst I've heard is Q2 call. I think Q3 or Q4 is more standard, and I've also heard Q5. But it's a function of how many hospitals you're covering, how many trainees are available, and what sort of services you'll be providing. But that said, it's certainly not a walk in the park. And I think the hours that you're working as a trainee in IR, or at least during your IR specific rotations, are probably easily 11, 12-hour days. And you can speak to this right now. I mean, you probably woke up at 5 and you came back at 7. It's not it's not a walk in the park by any means. But I will say that during my intern year, when I was on interventional radiology as compared to maybe a general medicine month, the time I spent was like, it was almost inconsequential, and that like the day kind of flew by because I was enjoying it so much. And I think that's sort of a really good sign of you doing something you really love, and it just being a natural part of your day. Um, to kind of talk about that a little bit further, the training doesn't necessarily reflect your future life. Like, there are a lot of different practices. Most trainees will be in academic practices, which makes sense, and they can be more demanding, definitely. And I think when you go out into practice, or at least from what I've heard, there's a whole lot of variety in the practice type you can choose from or be hired to. And that you can, if you want to, you can work that 7 to 4, 7 to 8 to 5 job if you'd like, or you can be extremely, prolific and work even more than you would at a major academic center, or and so it really, I think, the training will be hard. Hopefully it'll prepare you. It should prepare you, and then whatever you want to do afterwards is really, your lifestyle. It can be highly variable. It's really up to what you're looking for and what you want.
Yeah, I think that's an excellent point. I mean, versus a field like, say, like neurosurgery, I've had a neurosurgeon on the podcast. We talk about this, that, you're it's pretty hard to have a limited hour, just, much more limited hours attending job as a neurosurgeon. It's just the nature of the job. Or like interventional cardiology, where you're on call all the time, and, you're getting called in to do, STEMIs and things like that. It's just much more difficult versus IR. I think, you have much more control over, like you said, your hours, your schedule, how much you're on call, things like that. Because you could decide, there's some IRs that just don't do certain procedures that would be more, like, for example, some IRs don't do, or a number of them don't do any peripheral artery disease work, or something like that, that may require, more follow-up, more, more clinical workup, things like that. Requiring patients to be rounded on in the hospital and things like that. Some IRs, they do exclusively outpatient, or maybe, vast majority of their practice is outpatient work, so they're almost never going to the hospital.
Mm-hmm.
Versus, some of the attendees we work with, do very high level, complex cases.
Right.
So I think that's another nice thing, I guess, is the variety of cases you can do as an attending, and then off of that, the variety of lifestyles you can have.
I think what we're conventionally told is that there's a trade-off. When you're in an academic center, you can do more complex cases, and then when you go to like a community practice, you end up doing more bread and butter cases. I don't know that that's necessarily true anymore. And I think we both listened to different IR lectures that kind of focus on this very fact that there's a lot of private practices these days that do high end, high level IR, without necessarily the academic setting. And so
Mm-hmm.
there's a lot of mixing and matching of practice types, cases, like very diverse to very common. And so it's I'm kind of curious to see where it goes by the time we're looking at that same job market. um, but I think at the very least right now, I think you can, I would hope you could find what you want.
Mm-hmm. Definitely. um I think, kind of going back to your medical school days, I guess, what made you pursue IR? Like, what, when you were going through med school, was it something you came to during your third year, or was it something you thought you were going to probably do before that? And kind of what solidified your decision to do that?
Yeah, so I mean it's interesting. So I decided very early on. I decided the winter of my first year of medical school that I'd be doing IR, and that was it. And I
Wow.
never looked back. But I think that to give that some more context, after graduating from college, or I should say during college, I had a lecture on TIPS. It was kind
Mm-hmm.
of stored in my head somewhere. I never thought about it until med school. And then I went to do some research, bench research during my gap years in the city, in New York City. And that's when I really came to enjoy, doing research and really thinking about cancer and like what we can do for these types of patients. Um, and it was a lot of my research was focused around targeted therapy, and like I was like, man, like these systemic chemotherapies just really wreck people,
Mhm.
really wreck our patients, and there's such terrible side effects. Like there's got to be a better way to do this, and there's got to be more a localized way of doing this, and I'm keying words here that basically hone in on what IR does, which is local regional therapy. But come med school, I did this in a very systematic way. I literally opened up the AAMC specialty lists, and I just went down every single like primary and subspecialty and said, this looks interesting, this doesn't look interesting, this is something I need to rule out or really think about again. And after doing that, I did some shadowing of these different specialties that I needed to rule in or rule out. And by the end of the first semester, I was like, this, I think all roads lead to IR. And that's when I set up my first mentor meeting. Um, I think more commonly now, like the story I hear the most often is that there's a third year medical student who's following a patient down to get serviced in IR, whether it's for a catheter placement or for some trauma workup or traumatic embolization. And then they discover this, like, who are these magicians that do work and send patients back to the primary floor? And that's a story I've heard a lot. And certainly I think that model of like coming to know about IR, or like IR awareness, is changing, especially as compared to when I was first exposed. I think the number of interventional radiology interest group chapters across the country, as shown by the Society of Interventional Radiology website, has just exploded. And I'd be surprised if in every state, or almost, I'd say like 90% of med schools, there wasn't some sort of chapter that focused on promoting interventional radiology.
That's awesome. And I think one thing I'll plug for John here is, he's been very involved with the SIR, the Society of Interventional Radiology, and he was on a panel not too long ago advising medical students. I think it was about away rotations, right?
Yeah.
How to select your rotations, how to prepare for them, how to perform on them, and you should certainly, we can put the link to that in the show notes. You should certainly check that out if you're at that stage. But I think you point out that's a great resource for people interested in IR and who want to learn more about it.
Yeah, certainly. I think the society has a lot of great resources. No need to recreate the wheel here. There's a lot of people that have given good advice. And as Maxwell said recently, I was able to give some advice on a podcast that featured myself as well as other recent, now residents that went through the process.
Nice. So I think based on that, kind of maybe going off that a little bit, what's like, obviously you had a whole panel discussion devoted to it, but I guess what's your general advice for students, applying to interventional radiology residency if they're at that stage, and then going off that for selecting and doing well on away rotations?
Yeah, so I would say it really depends at which stage that you've decided to pursue interventional radiology. And I think the earlier you choose, the more options you have to craft your application accordingly. I don't think it's any secret that interventional radiology is extremely competitive. And so, I'll leave the listeners to go to the NRMP, data sheets and find out what, scores they should be targeting, or like how many publications they should be looking to, or what's, on average for the matriculated applicant. But I think, if you're finding out that IR is a way for you as a first or second year, or even like an early third year, I think it allows you the time to, develop really good relationships with mentors within your hospital. If there aren't mentors, it gives you times to find mentors outside of your hospital as well. And I'd say that's probably the biggest first step that anyone can take towards, you know, going on this path. Uh, Mentors are huge for any field, and I think that's like just a solid first step to take in getting guidance on, one, like, is this the field for you? um, Getting access to shadowing opportunities, exploring opportunities to set up a rotation or to do a home rotation. Um, and then I think, if you're earlier on, you may be able to develop longitudinal research projects. If you're coming in a little later, maybe there are case reports that you can write up. All things to show that you're interested in this field, and just another way to sort of try to make yourself stand out or highlight your interest in IR through different means. And I think everyone has different ways of doing this, different interests that align with them. For some, it's like public health. For others, it's about innovation, such as myself. Um, Others yet, the basic science research that really elucidate the mechanisms behind the interventional procedures. And to some extent, it's going to be a function of what's available at your respective university or college. And so, take that, do what you can. I don't think anyone's certainly going to penalize you for not having as much as someone in a different academic setting. That said, I think once again, the earlier you start, the more opportunities you can expose yourself to. I was referring to the Society of Interventional Radiology earlier, or SIR, and SIR has summer internship programs, research opportunities, medical student grants, and I was personally involved in my local interventional radiology interest group. Um, you know, we hosted a regional symposium, and then I was also actively involved in um, hosting or developing different programming for the Biodesign and Innovation Committee as a member of the SIR Medical Student Committee. So earlier on, more opportunities. Later on, you don't have as many opportunities, but I don't think it necessarily locks you out of anything. It just means that the way you approach your application might be slightly different. Um, but yeah, I think, I can't emphasize enough the importance that mentors have, and that's also sort of a reflection of my own personal experience.
Sure, sure. I guess one thing I'm thinking as you're talking here, let's say, obviously every medicine has to do the core, like medicine, surgery, things like that. And I'm sure you would agree with this. I would advise that you should do well on, especially those medicine and surgery, because, as we said, you may end up doing an intern year in them and they're just directly relatable to, what you're going to do as a radiologist. But let's say they have like some elective time. Should they do, I think some may be wondering, should I do a diagnostic rotation? Should I do an IR rotation? Should I try to do both? I guess kind of what are your thoughts on that? I mean, obviously it's dependent, like you said, on your school and how much elective time you have, but
Yeah, I mean, I think given the opportunity, doing both is always probably, at least in my perspective, like, ideal. Um, and a lot of my mentors told me this, like time and time again. They're like, John, if you really want to do IR, make sure you really, really enjoy and like diagnostic radiology too, because that
Mhm.
is the foundation upon which IR is built. And so earlier on, I don't think I took that to heart as much, and so I would like keep shadowing like IR only, and then eventually I think it hit on me that if I want to really understand the principles in the suite or in the rooms a little better, uh, my learning would be enhanced by having a greater diagnostic understanding, which is like such a common concept that I should have understood much earlier on. And so, I think I spent more time in the reading rooms with the diagnostic attendings, and limited as that may have been, I think it really helped me understand the sort of work that radiologists do in general, um, and helped really enhance my learning opportunities in IR. Um, I'd say if you had to choose one, I would say do diagnostic radiology, because Like that's you just have to like that. Like if you don't enjoy that, there's really no point in doing IR. Like at least from my perspective, and it really wouldn't make sense because such a large portion of your training is dedicated to diagnostic radiology alone. That I mean, it would just be insufferable if you didn't enjoy it. So I mean, that being said, like I enjoyed every aspect of both DR and IR. So it just made a lot of sense. Yeah.
Yeah, I think that's an excellent point. As we talk about the first, whether you're diagnostic or integrated, the first 3 years of radiology residency are by far majority diagnostic rotations. I mean, like I'll do IR here, and most likely won't do it for a long time, probably till the next year of training. And like yourself, like you did it, during intern year, which is not a common thing. A lot of times people aren't able to do IR during their intern year. I think that's kind of a benefit of our program. And then you always tell me, you're gonna have to wait so long. I think you said you do it at the end of the year.
Yeah.
So, and the rest of that time is spent doing diagnostic rotation. Cause at the end of the day, you have to get board certified in diagnostic to do it. It's similar to the people who do, like vascular surgery, and they get boarded in general surgery before they go to vascular surgery, and get boarded in that, or plastic surgery, or what have you, or cardiothoracic. So it's a definitely a prerequisite, but it's a prerequisite for a reason. It certainly makes you a better interventional radiologist for sure.
Yeah. Cannot be emphasized enough. Two are just so intimately entwined.
Yeah, and I think I don't even know if I've mentioned this, but I think one of the biggest difference I've noticed, wasn't I only did it a few months ago towards the end of intern year, the IR rotation, and now I'm doing it again. It's after doing a couple, rotations in chest imaging and abdominal imaging. I'd say the biggest difference I noticed for myself is I just look at things a little bit differently now because of, having that imaging training. And like when I'm looking at the imaging, I think like you mentioned, a huge part of working the patients up is reviewing the imaging. A lot of times when the providers call us or they consult us, they're not just relying on our clinical acumen or our ability to do the procedure or not. They're really also relying on the fact that we are inherently radiologists at heart, and that we are very well trained, obviously highly trained in reviewing imaging, to make not only help make a diagnostic call, but whether procedures indicated or not. So I think that's, for myself, even I have a better understanding of things from an imaging perspective, which I think has helped significantly.
Yeah, no doubt. I'm looking forward to having that same experience.
Yeah.
Yeah.
Yeah, yours will be much more significant than mine because you'll be towards the end. You'll have paid your dues, to say the least.
Yeah, certainly.
I guess we'll touch on it very briefly. IR away rotations, I guess, what are kind of the general themes you advise people on? I know you get asked about this a lot by both, medical students here at Emory, John is a wealth of knowledge on many, many things, as you're finding out. So, and he has all these, I don't even know how these people find John, but they find him, and they find him, and they want to pick his brain. So I guess we have the privilege of doing that here on the program. So
happy to oblige. So, I mean, choose wisely. But I mean, seriously though, like I think like obviously do that home rotation first to get your solid grounding and basic skills of working up consults and doing basic back table handling of devices and wires. And then I think when you're thinking about ways, like it can be at a place where you're targeting, where you'd really like to go, or it can be at an institution that you would like to receive a letter from, or it can be at an institution that you could see yourself at. I think it's changing right now. A lot of people with the whole pandemic and the resurgence there's been limitations to, at least the medical students I'm talking to, they can only do one IR rotation, like away rotation. And so I think the theme right now is that a lot of medical students are choosing that one place where they really would like to see themselves in training. Um, and I think that's a totally reasonable approach. And I think for others, it may be that they're, you know, interested in a particular region of the country that they would like to quote unquote open up for their interviews. And so they do an away elective in California, for example, to open up, you know, the West Coast, so to speak, and to show that their interest and that, you know, they are willing to make the effort, so to speak, to go to the West and to do that rotation. I think it's really going to come down to like where you see yourself the most. Um, and I think you have to keep in mind that, keep in mind your own like personal like application limitations, as well as, you know, where people may have historically gone to from your institution. And I don't think either of those are necessarily like hard limitations on where you can go. And, you know, like the sky's the limit. I don't know. But I think you have to almost like factor all of these things in as you sort of wisely or prudently apply to a wide spectrum of programs.
Yeah, I think that's an excellent point. I mean, I think, you know, if you want to shoot for some of the higher ranked programs or, you know, more academic programs per se, I
Yeah.
think that's certainly reasonable. But also I think, like you said, kind of evaluating where you kind of fit in all of that with your, you know, your stats, your med school, where people have gone from your med school, things like that, I think are probably important to apply, because I feel like in a way it could really help you stand out at a place, really help you get noticed at a place. And you don't want to do it at a place that maybe wouldn't necessarily, you want to do it at a place that's going to give you like a pretty good shot, I feel like.
Yeah, I think so. You know, if you notice that a program has historically only taken their own like medical students, I don't know that there's a whole lot of value in doing like away rotation there on the off chance that you'd be selected. Uh, that said, you never know, and you know, if you want to give it uh, your best effort and see what happens, I think that's a personal decision. Um, I think you have to choose practically and be reasonable about expectations, and you know, just prepare yourself as best you can, and you know, put your best foot forward, and leave the rest, but within like certain confines of reasonableness, I would say. Yeah.
Mm-hmm. I guess one last thing to kind of wrap up the application aspect of things is, for people applying IR, do you advise people to apply both IR and diagnostic radiology, just because from the fact that there's just a smaller number of programs and you'd want to make sure you at least get a slot? Because I feel like I've heard of people doing both. Some just exclusively apply IRs, many apply both. I guess, what are your thoughts on that? I mean, obviously you can also just apply diagnostic and then go to IR eventually and through the ESIR path. But I guess for people that want to apply integrated IR, what's your kind of take on that?
Yeah, I mean, if your eventual goal is IR, I don't think it should matter which pathway you take. It's going to end up being a 6 or 7 year process regardless.
Mm-hmm.
And you know, there, as we spoke earlier, inherent advantages to each of the pathways. I'd say as a medical student applying, if you know you want to do IR, like go for it. I think there's a lot of benefits to it. And I think the way it worked, at least when I applied, and the way I believe it still is that when you apply for an IR/DR position, that's usually what you're invited to for the interview. You're invited to interview for both the integrated IR program as well as the diagnostic radiology residency. So for many of my programs, I ended up, I would go to one interview
Mhm.
but end up ranking two separate programs, one the IR, DR, and also like a separate diagnostic program as well. And I think that is an option at most places. They rank you for both the IR and the diagnostic programs. Um, yeah, I would certainly do that. And if you run out of, I don't know, you theoretically ran out of IR programs that you're interested in applying to, and you only see DR programs in the region of, interest. Let's say that you're targeting the Southeast. Then I would certainly then, like in my head at least, look towards diagnostic programs with ESIR options, which kind of signifies to me that they have a certain level of training interest to pursue that pathway and the volume to support that level of training to cut 1 year from what your eventual independent residency would be. Um, yeah, and then after that, how you decide to rank the different diagnostic programs without ESIR is probably a matter of personal preference.
Sure, sure. Yeah, so it seems like, especially those ones where you'd be interviewing at both anyway. I mean, what's the harm in probably, applying to and ranking both of them?
Exactly. Yeah, I think it's that just happened. I think they considered you for both, and in most cases, I think there were only a handful of places that didn't. Yeah.
Okay. Yeah, no, that's good to know. And I feel like also if a place has an integrated program in place, they probably have a probably decent size ESIR program as well. So that's, if you can't get there for IR, it's probably a good place to end up for diagnostic and going the ESIR route as well, I would imagine.
Yeah, exactly. I completely agree with that. Yeah.
Nice, nice. I guess just kind of wrapping things up here. I guess tell us a little bit about BioFlow design or excuse me, BioFlow devices, and then your experience as a physician inventor and an entrepreneur, and kind of what kind of sparked this idea and kind of where things are now.
Yeah. So I am no engineer by training. I studied biology in college and had an English minor, and I was completely new to this. But I think, um, as maybe mechanical as my way to hair sounded from like, how I systematically, went through and ruled things in and out. One of the biggest attractions to me about IR was the innovative aspect, sort of like, pushing the frontiers, really trying to change the way we do things and questioning the status quo. I think I found all of those really attractive traits of the field. And I think I remember one of my mentors, Dr. Gary Siskin at Albany, was saying that a lot of the things that he was doing now in his practice, at least half of them he didn't learn in his fellowship training,
Mhm.
which to me was a really awesome sign that the field is growing and there's a lot of growth that will continue to be seen. And I think that's just like very evident in all the research that's coming out and the things that are being pursued. Um, Not to get distracted here. So during my third year, I was involved in um, a variety of like biodesign and innovation events through the National Society. Um, and then that kind of had me thinking more innovatively. And when I was on rotation in nephrology during my third year medicine consults, I saw a patient that had repeatedly gone down to IR for nephrostomy occlusion, requiring multiple exchanges. This was um, a patient who was trying to find her way back home, but continued to end up remaining in the hospital. And she had, you know, bilateral ureteral obstructions due to a pelvic mass. And so, I think over the period of 1 week, she went down to IR twice.
Wow.
And from following up with her, I think she ended up staying for a total of like, 20 days almost, and had more exchanges after the fact. initially due to what we suspected to be like biofilm occlusions, which brought her in initially. She was infected, and then they treated her with antibiotics, going through the common pathway, and then once she stabilized, sent down to IR. And then the days following that, she continued to have, clots in her nephrostomies. And so, just speaking with her, you have all this time as a medical student, of course, and speaking with
Yeah.
her, just like, darn, this isn't right. Like, why are we doing this? Why are tubes so primitive? Like, can we do this better? And I think that's where, there was just this switch that, turned on in my head, and I couldn't stop thinking about how can I make this better? And it almost became this puzzle I needed to solve. And I think over the course of that year, I finally came up with a design that I thought was viable. I presented it to my wonderful mentors at Albany, and then immediately went to our affiliated accelerator, where I was able to meet wonderful mentors in the business sector, Amy Johnson, namely. And so they really helped me develop a sense for what it would take to get a product from ideation to prototype to commercialization. And so currently, my work has been around percutaneous drainage catheters and developing a dynamic mechanism for preventing uh, occlusion from biofilm accumulation, mineral incrustation, biliary sludge, you name it.
Hmm.
Anything that causes obstruction, I'm hoping to obviate the need for an exchange by way of this mechanism that I've now patented. Um, and where we currently are, when I came down to Emory, I was thankfully really connected to the Georgia Tech engineers, the Georgia Tech resources, as well as Emory's resources, and have had the opportunity to collaborate with these wonderful students and professors that have really taken the initial alpha prototype to a close beta prototype. And we're now at the stage where we're approaching contract engineering firms to really look at, can we take this to a pre-production state or prototype that we can then use in anatomical model simulations or clinical studies to validate its use in clinical, being really preclinical work in animal models.
That's amazing. Um, it's most people just kind of get through med school and do their thing, but very few invent a device and then start a company and continue with it and bring it all the way to where you are right now. So I congratulate you on your
Yeah, no,
new
thank you.
success and your many more. And like I said, John's not only a wealth of knowledge on IR, but also medical innovation. I can speak to that myself. I've certainly learned a lot from him. We're in the early stages of collaborating on some additional, if he hasn't busy enough with one project, he's got all these ideas. So I'm certainly learning a lot from him as well. I think, you touched on it about mentorship. And I guess if a med student out there is listening to this and they think, or even a resident for that matter, they come up with an idea that they think is interesting, could be innovative. I guess what's your, like, because it could be intimidating, like, especially, you said you didn't have an engineering background. Like, where do you start? Like, where do you go? Like, do you go to someone? Do you try to make it a good idea or do some research on it? Like, what's your kind of advice for that?
Yeah, I think I stumbled a lot and sort of figured things out along the way, and hopefully people listening to this can benefit from my experience and not have to do the same. I would say that once you come up with some sort of solution, or like, once you come up with a problem, make sure it's a real problem, and spend the time to, talk to your mentors, your clinical mentors, make sure it's a problem. You design a solution, validate that feasibility and like user end, from the interventional radiologist or whoever's using that device, and make sure that it's at least, preliminarily a valid or validated, I should say, problem and proposed solution. I think after that point, you it would be great if you found a clinical mentor that has experience in this in innovation and entrepreneurship. That would be the ideal solution. I think they would provide all aspects of mentorship you would need. But I think and this is probably more normal, is that you find your clinical mentors who can help you validate problem and propose solution, and then you find someone who's in the entrepreneurship and commercialization side of things, and you find a mentor there who, these people tend to be mentors you can find in accelerators. And if your university doesn't have one, there's typically regional accelerators, whether it's in your state or in the general region. Um, and if none of that's available, I think you can always think about going outside of that region and trying to network through your mentors and asking if there's someone that you can be connected to. But I think finding those mentors first is certainly really important. I think one thing I realized as a medical student inventor was, and I found this out the hard way, is not understanding the IP ownership or landscape that the university has of your invention as a medical student. And I went through a lot of conversations with the University Office of Technology and Transfer Office, just trying to clarify what hold they might have over anything I develop. And really, it came down to, did I use university resources or not as a student? And because I did not, I was able to have my um, invention, released, quote unquote, by the university, for me to pursue work with it out, like independent of the university having any ownership. It can be a little convoluted, I think, but at some point, while you're looking for mentorship and you have that initial proposed solution, I think trying to understand your local university's IP policies might be very helpful, because you'll soon be transitioning out of that medical school. Possibly, more than likely, you'll be leaving that medical school for a different program or a different residency in a different place. And it can be very unattractive for future investors, should it ever get to that point, for multiple universities have a hold of the IP in different forms. And it's just better to keep things clean and simple. And so I would think about that. Depending on the amount of time you have, you can pick up different like engineering pseudo skills, as I call it, that may help you. Like I dabbled in CAD for a bit, just to get my bearings on engineer speak. Um, but I think those are like the first preliminary steps I would take if I were kind of mentoring a medical student, and definitely not approaching industry right away. And taking the time to develop your designs, your IP, and there's a whole process that you go through from like ideation to prototype to like clinical model. Like there's a lot of steps in between, like hundreds of steps, and like many people you talk to. I would highly recommend looking at um, the Stanford Biodesign textbook. It's classic and teaches you everything you need to know. And I'll leave it at that for now. It's almost an entire podcast in itself.
Yeah, no, I mean, I think, we'll have to have you on again sometime and probably dive in deeper on that. I think there'd be a lot of people interested in that
For
whole
sure.
process
Yeah.
as well. But I think just kind of wrapping things up here, I think, very innovative career you've had going on here. Definitely one of the busiest guys I know, for sure.
Speak for
uh,
yourself. Thanks.
and so I think when you aren't doing, we ask everybody this, when you're not, building medical devices or doing interventional radiology, what are your pastimes outside the hospital? How do you balance yourself if you can?
Yeah. I think you know this. I play tennis. I know we play tennis every so often.
Mhm.
I like sports in general, so I'll do anything to engage in physical activity. I'd say, my primary hobby is probably just hanging out with the friends, our colleagues, hanging
Hmm.
out with people, and just having a good time, like with good food, good company, um, just sharing our experiences. I think all of that is kind of like what I do outside of or in my free time, I should say. Yeah.
Yeah, and I think you bring up important point there. It's important to spend time with your colleagues, assuming you like your colleagues outside of the hospital. Because no one gets it. Obviously you can talk to your significant other or your parents, or your brother or sister, or a close
Yeah.
friend or whoever. But I think no one gets it more than your own colleagues, at your
Yeah.
program or at your
Yeah.
medical school, than what your the frustrations, and then also we certainly talk about those, and then the positive aspects as well. It's if you're having a funny story or an exciting day, it can be, even those can be harder for some people who aren't in it to understand. So I think that's important as well.
Yeah, I think I used to always look towards like the next step. It was like, when I was in a pre-med, I would look towards med school. When I was in med
Hmm.
school, I looked towards fourth year, and then residency, and then residency happened, and I was like, oh, intern year, I'm looking forward to radiology. Now we're really in it, and I think um, it's just a wonderful field. I would highly encourage any medical students interested in or open to radiology to explore it at the very least and give it a solid try. I think more people, a lot of people don't give it the time it deserves, I think, and would be surprised to find that they may actually really like it.
Yeah, no, I agree. And it's something I wasn't initially interested in, but came to it over time, as you know. And I love it now. I think it's such an innovative field, and and it's this is clinical. I think it gets kind of a bad rap sometimes. They're like, oh, you don't see patients, so there's limited patient care. Um, I mean, unfortunately, as we talk about a lot of specialties anymore, you spend a lot of time at the computer. I mean, whether you're a medicine doctor, a surgeon, an ICU doctor, you spend time away from patients. And so I think,
Yeah.
obviously radiologists, it's on you spend more time at the computer, in terms of reading images. But as far as IR, like I mentioned, we're, as much a consult service as any other. I mean, we're out there, seeing patients and, doing procedures on patients and doing clinic, like you mentioned. And I think that's so it's really, it can be as little clinical exposure as you want. I mean, some people don't want much clinical exposure, and that's part of the
Yeah.
reason they go into it. But or all the way to, a significant amount. And then there's a lot of diagnostic physicians that do a lot of, procedures and interact, they do like biopsies, and a lot of
Yeah.
the musculoskeletal radiologists do a lot of interesting, procedures as well, where they interact with patients. So I think there's more patient interaction than people realize.
Oh yeah, absolutely. I mean, I wasn't expecting to do so much patient interaction on my like abdominal body rotation when
Hmm.
I was doing fluoroscopy
Sure.
for fluoroscopic studies on patients. That took up the majority of my day. Um, but yeah, I think for those medical students listening, check it out. It's an amazing field, one that I love, one that I know Max loves, and it's just it's really the future of you know diagnostic medicine as well as like interventional therapies. So yeah, I know what more can be said.
Yeah, and I think with that, we'll kind of wrap things up. I guess, I know you're relatively active on Twitter. What's your, do you want us to plug any things for people to follow for you?
Oh yeah, I can share my Twitter account, and maybe you could post it on the link. But I'm happy to
Yeah.
share that if any interested medical students are want to reach out to me. Happy to chat. So yeah, thanks for having me. Again, really enjoyed talking with you about this topic. This is a great podcast.
Yeah, no, yeah, but no, we're glad to have you on. Like I said, you're a wealth of knowledge in many things. So I think the listeners will gain a lot of value from this, and we look forward to having you on again sometime. So with
All
that,
right.
thanks again, John. Appreciate it.
Thank you. All right. See ya.
Thank you for listening to this episode of the DaVinci Hour, brought to you by DaVinci Academy. More episodes are available on our website at dviacademy.com, our YouTube channel. They're also available on Spotify and Apple Podcasts. Also on our website, you can find our video courses for anatomy, biochemistry, and histology, and they're available as month-to-month packages. They're also available as a combo package where you can get all 3 courses in one. Our website also has a store where you can find our outline format textbooks for anatomy, biochemistry, and histology. All textbooks are available in paperback version and as eBooks as well. These textbooks complement our video courses and provide a nice addition to the learning experience of allowing you to focus on the learning and not having to write anything down. On our website, we also provide a free clinical cases video series called DaVinci Cases. DaVinci Cases aims to help you learn how to answer USMLE questions and apply concepts that you learn in our courses to answering those questions. Our cases cover a variety of topics and organ systems, and they're updated frequently with new cases. And then lastly, on our website, you can find our blog, which has interesting articles that cover medical history, important figures in medicine, and innovations in medicine. Again, thank you for listening to this episode of the DaVinci Hour, brought to you by DaVinci Academy. Please be sure to tune in for our next episode.